The Journey of David. After receiving the results of a routine exam with his general practitioner, David was referred to a nephrologist due to alterations in his urine analysis, which showed proteinuria. David lost a lot in his social life during adolescence. He felt like not being shirtless in swimming pool due to small red spots in the belly. Frequently depressed and sad, a new warning was coming. Time goes by, and David grew up a young man with non-stop episodes of diarrhea and stomachache. When asked about family history, David remembered of 2 relatives that were on dialysis. In the meantime, he got a routine appointment with an ophthalmologist who diagnosed an alteration called cornea verticillata. At this point, nobody ever had the idea of putting together all those symptoms. The nephrologist decided to repeat the urine analysis that showed proteinuria, and at this point, the physicians agreed to investigate his condition further with additional blood exams such as creatinine and urea levels and ECG. The results showed normal urea, creatinine of 1.5 milligrams per deciliter, which corresponds to eGFR 60 milliliters per minute, daily proteinuria of 1 gram, and ECG with increased Sokolov index. The nephrologist was concerned about the results, and urine and blood exams indicated loss of renal function. Uncommon for his age, what made him indicate a kidney biopsy? However, David refused to undergo such an invasive exam, which was a challenge to the nephrologist, who has now to put all pieces together to correctly diagnose David's disease. The combination of loss of renal function, history of neuropathic pain, angiokeratoma, and positive family history of renal disease guided him to investigate the possibility of Fabry disease. To have it confirmed, he performed an enzymatic test, which demonstrated less than 1% of enzyme activity. To certify the diagnosis, David underwent a DNA analysis, and the result was a pathological mutation associated with classic phenotype of Fabry disease. Fabry disease is a genetic disease caused by egg galactosidase A deficiency. The enzymatic defect leads to progressive accumulation of the glycolipid glybultriosylceramide in the lysosomes in the cells of most organs. Renal involvement of Fabry disease is mainly manifested by glomerular hyperfiltration, microalbuminuria, and proteinuria before end-stage chronic renal disease. For a better understanding on how Fabry disease affects the kidney, it is important to follow the similarity between Fabry nephropathy and diabetic nephropathy. In diabetes, the accumulated metabolic is glucose, while in Fabry disease is GB3 and lyso-GB3. The main target cells in both diseases is the podocyte, which leads to proteinuria. The release of secondary mediators present in both conditions leads to a progression in kidney injury, leading to inflammation and fibrosis. If the treatment is not started early enough, the patient will develop end-stage renal disease. The pathogenesis of kidney involvement in Fabry disease relies on the accumulation of GB3 and lyso-GB3. This last one shows elevated plasma levels and acts as an excellent biomarker of disease activity. This process causes podocyte effacement and loss, and consequently will lead to progression of nephropathy and end-stage renal disease with need of renal replacement therapy, dialysis, or kidney transplant. Symptoms of Fabry disease may change throughout life. During childhood, the patient commonly faces pain crisis, intolerance to extreme temperatures, and hypohidrosis and hydrosis. In adolescence, early adulthood, the patient usually complains about fatigue and develops proteinuria. And in adult life, more serious symptoms and severe complications of Fabry disease can affect the patient, such as renal insufficiency, cardiovascular complications, and also cerebrovascular disease. Fabry disease is an X-linked genetic disease. An affected male only transmits it to his daughters, while an affected female may transmit to both daughters and sons. That's why the family pedigree is a powerful tool to help clinicians identify at-risk family members, establish the inheritance pattern, and early diagnose potentially affected relatives. David has been diagnosed with Fabry disease and is under treatment, but his journey is not ended yet. Now his relatives will undergo family screening. The earlier the diagnosis is made and treatment initiated, the better are the chances of avoiding irreversible complications. You can make the difference and dramatically reduce the journey of patients like David. So ask yourself, why not Fabry?